Okay, so let's go ahead and get started. Welcome to everybody who's joining in today for the Haynes method of neuromuscular dry needling, the Genicular Protocol. This is a protocol that I developed about a year ago in an attempt to supplement the dry needling procedures that I was already doing through other research that was out there for NeoA and degenerative joint disease. So let's jump right into this and move on there. All right, so let me see if I can do it. There we go. So we're going to take some time today to talk about what the Genicular Protocol is, who it would be beneficial for, what diagnosis and conditions, and why and how the protocol was developed. We'll talk to a patient that is currently being treated through the protocol and get her opinion of what she sees with it. We'll then take a look at some three-dimensional anatomy to determine exactly where the genicular nerves are located and the procedure we take to dry needle those nerves. We'll briefly review the precautions associated with dry needling, the expected outcomes from perineural dry needling, and perform the actual dry needling procedure for the genicular nerves. During the webinar, if you have questions, keep them in your head or make a note of them. And at the end, feel free to reach out and contact me for answers for different issues or concerns or questions you may have concerning the Genicular Protocol. So, patient conditions that would benefit from the Genicular Protocol. There are a lot of potential conditions that can be treated through dry needling. The above, for example, quadriceps tendinitis, patellar tendinitis, patellar bursitis, the supra, the subq, the infra, knee osteoarthritis, pes bursitis, IT band syndrome, a Baker cyst, MCL, LCL strain, runner's knee. A lot of the specific syndromes that we look at, we can treat, and we have protocols developed for dry needling with that. However, of interest is the NeoA, which is where the genicular is really derived from. So why and how the Genicular Protocol was developed? Well, a few years back, one of my patients had DJD of the knee, has had limited success treating through the NeoA dry needling protocol. She went to a pain management group and they did a genicular nerve block. Well, she ended up having 3-4 very good weeks of very minimal pain by applying that genicular nerve block. So I talked with the anesthesiologist, talked about how they did that, the nerves associated, and I started to think about how we could apply that using our dry needling approach. And so the nice thing, if we could have success with it, would be that we also weren't introducing steroid into the tissue, which we know can result in a more rapid breakdown of tissues when it's used for a longer term. So I reviewed the anesthesiology literature for different information. It seemed like most of the anesthesiologists were using a lot of the same sites. In practice, it seems most of them are doing the genicular block on the medial aspect, which is where we tend to see the majority of our pain associated with degenerative knee problems. However, we clinically see knee pain on the lateral aspect too. So ultimately, I selected this case study by Ahmed and Aurora from 2019 from Pain Practice that described the 6 points in detail. So what I wanted to do was take a little bit of time and talk with the patient that I'm seeing. Her name is Lois, and I'm going to...
Hi, my name is Luke. I'm a physical therapist here at Haynes Physical Therapy, and what we're talking about today is a genicular dry needling protocol that we've developed through our neuromuscular dry needling series. And wanted to give a little interview with one of the first people that I've used this procedure for, and her name is Lois. And Lois has agreed to be on film and demonstrate what's happening with her. A little history: Lois has had a past replacement of the left knee, and she's doing fairly well with that. And honestly, she probably needed to have the right knee done as well. Unfortunately, she's also taking care of her son, and at this point really can't afford to be away from doing that for 4 to 8 weeks while she's recovering. So she's elected to look at alternative ways of managing her knee pain during this time. And so we had gone through some different approaches and tried some different things. But ultimately, I had developed this genicular protocol based off of the anesthesiologist's injection sites for genicular nerve block. And we've had some fairly good results. And so I just wanted to talk with Lois a little bit about what she has seen so far with this. So if you would, tell me a little bit about your right knee pain and how that's been, how long it's been there and how it's been impacting your life.
Lots of years. In fact, when I had the left one replaced, we did a coin flip to see which one we were going to do first. We went with the left. So we're talking 10 years or more.
So quite a long
A
time.
long time, yeah. And pain was pretty intense, and it was hard to live with, but necessity I did.
Sure.
But since we started this, it's been completely different. The pain is bearable. In fact, there's days that pain is not there, so much less.
So since we started doing this genicular protocol, your daily activities, what would you say has happened to what you're able to do in a day since we started doing this?
Well, I'm able to walk better, and I can actually leave the cave in one room and go to another room, and I feel like I'm fixing to fall or the knee give out because of the intense pain. So that's a very, very big plus.
With the experience that you've had with this approach, is this something that you would recommend for people that have had an issue like this?
Definitely. Yeah.
Okay.
If my sister lived here, yeah, she'd be here. She's in Dallas. So.
Well, hopefully we can get the word out about what this is and somebody can take it on over there and apply to her as well. Okay.
So that's Lois' story. She has shown considerable improvement with her functional approach. So let's talk a little bit about some three-dimensional anatomy. When I teach this course to a live group of people, I will use a 3D anatomy program that really lets us delve into three-dimensional view of where these nerves are located, and it makes it easier to understand why we're placing the needles where we are. And then in this case, I'm just going to give you an overview of what we're looking at. So the first, let me come back here. All right, so first we're looking at the 6 genicular nerves: the superior medial genicular nerve, superior lateral genicular nerve, the medial genicular nerve, the recurrent perineal nerve, the inferior medial genicular, and the inferior lateral genicular nerve. The superior medial genicular, basically it is going to be at the location of the adductor tubercle on the medial aspect. It's going to be about 2 finger breadths superior to the medial joint line. The superior lateral genicular nerve is going to end up being about 1 finger breadth superior and lateral to the superolateral patellar pole. That's going to end up being needled at about a 45-degree angle. On the medial genicular nerve, again, similar landmark. This time we're going to be about 4 to 5 finger breadths superior to the superolateral patellar pole. We've been talking about finger breadths, and when I talk about finger breadths in relation to needle placement, I'm referring to the finger breadth of the patient, not the clinician or the therapist. So if you have a large patient and a small therapist, or vice versa, you can have a big disparity in the actual distance that you're looking at. So if you're needling this or any other protocols that we teach, it's always about the distances related to the patient's finger breadth. The recurrent perineal nerve basically sits just slightly inferior to Gertie's tubercle, which is the attachment side of the IT band. And the needle placement is between the anterior tib margin and the patellar ligament margin. The inferior medial genicular nerve is basically it's the anterior surface of the anserine bursa. So if you're treating somebody with for pes anserinus, that is the same needle location. Really, it's about 1 finger breadth distal to the medial joint line. And then the inferior lateral genicular nerve is going to be on the tibia, just inferior to the joint line on the lateral collateral ligament. So a little conversation about dry needling precautions, and this is just covers most all of the things that we would look at. One thing, just general contraindications, non-consent from patient. I know that seems obvious, but that verbal and written consent needs to be in place. First trimester of pregnancy is a good medical legal reason to stay away from that. The nipples, the umbilicus, external genitalia, if there's any uncontrolled anticoagulant usage, you want to stay away from that. A local infection, active tumor, a person with Chiari malformation, contraindicated to needle suboccipital into that, since we don't have a good idea of where that malformation is going to be situated. Somebody that has an implanted electronic device, a pacemaker, defibrillator, pain pump, any of the number of implanted devices, just don't want to needle onto those things. And into a site with post-surgical lymphedema. And those are contraindications. Some relative contraindications surgically. Any communicating tissue, you want to wait about 6 weeks before you needle those tissues. And in the local area itself, you want to wait a full 12 weeks just for concern over infection. If there is if the surgeon allows it, certainly that's the surgeon's discretion. You just want to clinically be aware of that and document it accordingly. And then some precautions. A lot of people can have just a needle phobia, needle aversion, significant cognitive impairment. It's hard to get feedback on the treatment itself. If there's pneumothorax or a history of it, that's definitely a precaution. Pneumothorax is probably the #1 issue that we get concerned about in relation to the trunk. If there's severe hyperalgesia, an abnormal bleeding tendency, or vascular disease. And then some additional precautions around an area of a breast implant, a person that's had a laminectomy, or if there's scoliosis or severe osteoporosis, just things to be aware of whenever dealing with dry needling. So perineural dry needling, it is becoming more prevalent when treating conditions in the extremities that include impingement of nerves such as the carpal and cubital tunnel syndrome. The peripheral mechanism is centered around decreasing localized inflammation in the tissues that are causing the impingement. But there's also a central desensitization that occurs, an interruption of the sensory afferents and nociceptors that are signaling the pain response. There's a sparsity of evidence concerning the mechanism of perineural dry needling, and more needs to be done with that. However, anecdotally, we are seeing good results. So let's now take a look at some surface anatomy.
So the first thing when we're talking about surface anatomy, first thing on this is we want to outline the patella, and really just the superior aspect. And most specifically, the superolateral border. And some of our needling landmarks are associated there. We then want to come in and identify the medial joint line. Okay, we're also going to want to come up and find the condylar ridge. It's just going to be a little bit of a drop off as it forms the border of the condyle here. We're going to drop and locate the pes tendons as they're crossing this medial joint line. So we know we're coming around here. And the medial collateral, it's a little bit difficult to palpate, but we're basically in a line right there. So here we have the pes, the medial collateral, here's the medial joint line, and then the condylar ridge. Then here's the patella. There. So the other structures we want to know also is the lateral joint line. We're going to want to know the lateral collateral as it drops. All right. We are going to need to know the medial border of the anterior tib. Will you lift your toe up for me? All right, there. And then relax. And then one more time. Very good. So the medial border of anterior tib, it's coming up. And then the lateral border of the patellar ligament. And so off of these lateral collateral, here's the anterior tib border, and then the patellar ligament there. All right, so the first needling location will be the superior medial genicular nerve. And where we're going to find that is basically at the adductor tubercle. So we're going to find the medial joint line, the condylar ridge, and we could have her contract the adductor to palpate for it, but we're going to end up being about 1 finger breadth above the condylar ridge. And so we'll place that needle location here. It's going to be completely medial to lateral to land onto that nerve. Okay, so the second one, so here is superior medial genicular nerve. The second will be the inferior medial genicular nerve, and it actually sits right at the pes bursa. So how we would normally come in if we were kneeling for some pes bursitis, it's going to be about 1 finger breadth below the medial joint line along the line of the MCL, between the MCL and the pes tendon next to it. And so that also is going to be, again, about 1 finger breadth below, so about right there. Again, it's going to be medial to lateral to land on that structure. And that's the inferior, can't write upside down, medial genicular nerve. So those are the 2 you're going to get from the medial aspect. The other 4 we're going to get from the lateral approach. All right, so the next we're going to do the superior lateral genicular nerve. And for here, we're going to end up being the location here is going to be about 1 finger breadth above the lateral patellar pole. And so we're going to come up 1 finger breadth, probably lateral finger breadth. And so here is our location here. And again, superior lateral genicular nerve. Writing upside down is challenging, that's wrong. And that's going to be about a 45-degree location here. The one after that, we're going to look at the median genicular nerve. And for the median or medial genicular nerve, we're actually going to use this same point, but we're going to come up 4 finger breadths. So when we talk about finger breadths, we're talking about her finger breadths. And after looking at hers, 4 to 5 of hers is about a good solid 3 of mine. And so on this one, our location, and I didn't draw this, is going to be right at the interface of the IT band and vastus lateralis. So you can have them push your knee out into my hand, if you will, up that way, to identify the IT band and relax. And so we know that it sits right at this level. Again, 4 to 5 finger breadths above the superlateral pole. And so we're going to be located right here. Now this, we don't have the femur as a backdrop. What we're going to do here is come just anterior to the femur to get the median genicular nerve. So that's spot 1, 2, 3, 4. All right, so the 5th is the inferior lateral genicular nerve, and it is going to be at the inferior aspect of the lateral collateral ligament. So it's going to have a tibial backdrop. So we follow our lateral joint line over to the LCL, going to drop down just a bit, maybe half of a finger breadth, and that is going to be lateral to medial with our needle trajectory. Our last one, which is the recurrent perineal nerve, is going to be at a spot between the anterior tib medial border and the patellar ligament. So you can also locate it at Gertie's tubercle as the IT band comes over and attaches on the tibia itself, but mid spot between these two borders below the tibial plateau, and that is the recurrent perineal nerve. So we have 1, 2, 3, 4 lateral locations, and then we have 2 medial locations.
Okay, and finally, let's move on to the actual needling application. We've looked at the surface anatomy, where we need to put the nerves, the relevant anatomy there, and pinpointing the locations. And now let's go ahead and look at the actual procedure.
Okay, again, for the superior medial genicular nerve, it's going to be a complete medial to lateral landing on the adductor tubercle. I'm going to come in. To there with a backdrop on above the condylar ridge. Okay, the second one on the medial aspect is the inferior medial genicular nerve, which sits at the anserine bursa. So I'm using a 6 centimeter needle on both of these. Needle length is always dependent on the patient's girth. And there will be a backdrop there. Very good. If you do need to scream, you can scream. For the medial genicular nerve, again, it's going to be at the intersection of the vastus lateralis and the IT band, and we're going to come lateral to medial, if anything, a slight anterior motion. So land just anterior to the femur. Again, that is a 6 centimeter needle. For the superior lateral genicular nerve, again, from the lateral patellar pole, superior lateral, it's going to be 1 finger breadth above and lateral. Stay out of the ink. I'm going to come a little bit further. And this is at about at a 45-degree angle. This is a shorter needle, about 3 centimeter. To there. For the inferior lateral genicular nerve, again, it's going to be inferior to the tibial plateau along the course of the lateral collateral ligament. Again, lateral to medial with a backdrop onto the tibia. And lastly, the recurrent perineal nerve in between anterior tib and patellar ligament. And this is about a 45-degree angle as well. To there. So needles are placed. Normally at this point, I will put electrical stimulation on 10, 15, 20 minutes. Ideally, it's a biphasic wave and frequency, maybe an alternating 2 hertz up to 100 hertz at about a 3-second interval. And so that is the placement of the needles.
So lastly, it's just some summary and conclusions. The Genicular Protocol that I've been using has shown me some really good results in dealing with NeoA, degenerative joint disease, and seeing some really good results. Obviously, we're not growing cartilage. We're not making permanent changes. It's just another method of managing pain symptoms. And I have some people that I see once a week, once every 2 weeks, and I have people that I've seen for a few weeks, and it's probably been 3 or 4 months that I've had to follow up with them. So my opinion, that is a better way of managing that knee pain by not introducing steroid into the system and getting a better functional outcome and result from it, giving the patient a choice of how they want to treat that. So I've got my information up here for my email address, my website, Facebook or Instagram post. I don't have my YouTube channel on there, but I've also got this recorded in a couple places on the YouTube channel. So if you have any questions, feel free to reach out to me. And I hope you'll consider applying this genicular protocol to your treatment approach. And to the researchers out there, would love to see some research on the efficacy of this compared to the NeoA or other treatment options. Thanks a lot. Yell if you have any questions.